students. We have invited them for this lecture series. Just 1 minute. Give me 1 minute, Shad bhai.
That's right. That's right.
Oh, Shad bhai, it's 9 o'clock now.
Okay.
So I think we will start rather than to waste time.
We will just start.
Yeah, it's okay. Yeah, no problem.
Yeah. Okay. Shad bhai.
Right. Okay. So, Shabai, you just started. Then I will take over. Yeah.
Okay. Just one.
Dr. Tazim is here. Dr. Tazim.
Wait, we start the recording. Just a minute. Okay, let me, yeah, Tazim, okay, I will unmute him.
Yeah, please.
Okay. So inshallah, we'll, first of all, assalamu alaikum wa rahmatullahi wa barakatuh. I welcome you all. No, I can't see him. Once he is here, I will unmute him.
Dr. Ashfaq, can we start?
Yes, we can start, inshallah. Yes.
Can you start with Tilawat Quran Pak and then we'll proceed.
Okay. Bismillahirrahmanirrahim. A'udhu billahi minash shaitanir rajim. Bismillahirrahmanirrahim. تبارك الذي بيده الملك وهو على كل شيء قدير الذي خلق الموت والحياة ليبلوكم أيكم أحسن عملا وهو العزيز الغفور. These verses are from Surah Al-Mulk. تبارك الذي بيده الملك, blessed is he in whose hand is the dominion. وهو على كل شيء قدير, and his power over everything. الذي خلق الموت والحياة, he is the one who created life and death. لِيَبْلُوَكُمْ أَيُّكُمْ أَحْسَنُ عَمَلًا, so that he can test who comes with good deeds. وَهُوَ الْعَزِيزُ الْعَفُورُ, he is exalted, powerful, and all-forgiving. Sadaqallahu al-Azim. I award this program further proceeding of medical series lectures by renowned expert. Now to our moderator, Dr. Shad Ahmad, please.
Thank you very much, Dr. Ashfaq. On behalf of PDGR, we are going to start our live webinar program, and today is the first lecture which will be presented to our PDGR president. He is our consultant cardiologist in Prince Sultan Medical City. To utilize this opportunity, I would like to say the PDGR to require our colleague and the members come forward and send to your topic, interesting topic. So we can, we can arrange the live webinar like today. So we started from our very senior person and consultant cardiologist. So I will just hand over to Dr. Tazim. Can you introduce our guest speaker and our speaker, the main speaker, please?
Tazim, I can't see Dr. Tazim.
Okay, leave it. So our speaker, it is Dr. Asadullah Roomi. He is a consultant cardiologist, Prince Sultan Cardiac Center, and he is our president of PDGR, Pakistan Doctors Group of Riyadh. So he will talk about the challenges of controlling hypertension. So without wasting the time, Dr. Asadullah Roomi, so please proceed. Thank you very much.
Thank you, Dr. Shad, for the introduction. Thank you, Dr. Ashfaq Bukhari, for arranging this webinar. The purpose of this lecture is basically our clinic doctors, those who are doing a great job from decades, and especially during the COVID time, they are doing the virtual consultation and they are helping the patients. Our objective today is to educate them, and we can learn from our experience. Our panel would be like Dr. Tazim and Dr. Shah, they are our moderators. And our senior consultant, Dr. Sultan, will be with us. He's an endocrinologist, and he will, if you have any question related to the endocrine hypertension, he will be with us. Dr. Naveed Aslam, consultant nephrologist, he will be with us for renal hypertension. And I'm sure Dr. Adil Sufi, our heart failure consultant, he will be with us as well. And Dr. Sajjad, a neurology consultant, he can, if you have to put some light on the stroke, hypertension, how to manage a stroke, so he will be there as well. So without delay, I will start the outline, the stages of hypertension and when to treat, diet, lifestyle, and medication approach to the hypertension. Resistant hypertension is 10-15% of the patients are very common, so its causes and treatment. Secondary causes of hypertension, almost 10% of the patients have secondary causes of hypertension, so how to approach and how to tailor the treatment for them, and malignant hypertension and their treatment. So these are the learning objectives. I will just throw some questions, and we will answer these questions in the end. And most of these presentations based on the guidelines, okay? So question number 1, based on 2017 ACC EHA guideline, which of the following medication is recommended as the initial therapy for a 56 years old black man, initial therapy with type 2 diabetes and hypertension. So 2 risk factors. Blood pressure is 152/87. Normal renal function, no proteinuria. Okay. So A is lisinopril, B is valsartan, C is diuretic, and D is atenolol. So you can read the question. I give you the highlight as well, and we will discuss this question answer in the end. Second question: a 62-year-old woman with history of left anterior descending stent. It means the patient has an acute MI or coronary artery disease, and we put a stent 2 years ago. Home blood pressure readings were 130 to 140 systolic, diastolic is 85. Office blood pressure is 138/87. His BMI is 32 kilogram per meter square. He walks 30 minutes a day. Based on the guideline, what blood pressure would prompt medication? A, systolic more than 130/80. B, systolic more than 140/80. C, systolic more than 145/80. D, systolic over 150. Diastolic is 90. So based on the guideline, which one is correct according to that patient? The last question: 69-year-old man, routine medical care, present to the ER department with sternal chest pain, diffuse pain radiating to the back. Blood pressure is 210/95, and he's tachycardic. Regular heart rhythm, rate is 115. So it's a case of dissection, right? ECG shows sinus tachycardia, LVS, CT angiogram to evaluate for dissection. You are asked which medication to use acutely to reduce the blood pressure. So remember, the key points are here: the blood pressure and the heart rate. What medication do you recommend? A or 1, intravenous nitroprusside, B, labetalol, C, intravenous hydralazine, 4, oral metoprolol. So the key here, heart rate. Remember this question, and we'll discuss in the end. So these are the current guidelines present by the basically by the Global Hypertension Society, published this year, June 2020. I would recommend all of you. These are maybe most likely 20 pages. Read it. It will really help you in your clinical practice when you're seeing a patient in your office. So 2017 guideline by the ACC EHA. These are the mainly guidelines I will follow. If you look at the prevalence of hypertension, the lifetime risk for developing hypertension is very high. And this is a study called MESA study, which is a multi-ethnic study of atherosclerosis. Okay. And why they done this study? Because in that study, they added the ethnical minorities of US. Okay. Usually you will see the studies between the African American and white, but this time they add Chinese and Hispanics. And they feel that the risk is very high, and almost in 93% in African American versus 86% for whites. And that study will give you the better understanding of the prevalence of hypertension in different ethnic groups. How to measure blood pressure is a very important slide. Okay. For our GPs, those who are our great doctors who are doing our clinics in the embassy clinic, So when the patient will come, make sure patient is relaxed, make sure the patient bladder is empty, make sure the patient is...
Dr. Roomi, I'm sorry to interrupt. I can receive the chat that they cannot see the screen. So could you please, from the participant can confirm, all of you can see the screen? Shad and Dr. Tazim? Because they are saying they cannot see the screen.
Dr. Shad, can you see the screen, please?
Unmute yourself, Dr. Shad.
Yeah, so I can, I can see the screen very clearly. There, I don't have any problem.
Okay, go ahead then. I think maybe this is one participant. Let me check the chat. If I can request, please, chat is only for question to Dr. Shad and Dr. Asad Roomi. Go ahead, Dr. Roomi, please.
Okay, so how to measure the blood pressure? I was telling you the patient should be comfortable, sitting on a chair. His feet should be flat on the floor. Don't cross the legs. Back should be supported. Arm should be resting on the table. And then, you know, a patient, like, you have to measure the blood pressure and multiple readings, you have to take it and so on. The most important thing, use a proper cuff. If you use a smaller cuff, you are overestimating the blood pressure. If you are using a bigger cuff, you are underestimating the blood pressure. So these things are very important. And whenever you see the first Krotokoff sound, it is a systolic blood pressure. The fifth Krotokoff sound, it is a diastolic blood pressure. Rest of the thing, you can read it from the guidelines I showed you in the beginning. So stages of hypertension. Optimal blood pressure, systolic less than 120 over 80 millimeter of mercury. Elevated blood pressure, 120 to 129 systolic, diastolic less than 80. Remember this thing. Hypertension is stage 1, when the systolic blood pressure from 130 to 139 and diastolic from 80 to 89 millimeter of mercury. And stage 2, this is a very renowned definition, when the systolic blood pressure over 140 and diastolic over 90. So this is, I'm going to present you a study, a case study of 1.3 million people. And case basically, this is the Northern California benefit group. And this study followed for 8 years. If you look at my left-hand circle, you can see the hypertension more than 140 over 90. And on my right-hand side circle, you can see the hypertension grade is 130 over 80. And these are the diagrammatic presentation for that. I would like you, all of you, to listen to my next 1 minute very carefully. In the latest European guidelines, the definition, they retain the previous definition of hypertension, which is more than 140 systolic and 90 diastolic. These are the latest current guidelines of the European Society. However, if you look at the right side, the American guidelines lower the threshold of hypertension to around 130 to 80. Anyone who has a blood pressure more than 130, they said it is abnormal according to the American guidelines. And American guidelines proposed a new definition driven largely by the, by the meta-analysis of different trials. And the main trial, it is a sprint trial, which is a systolic blood pressure interventional trial I'm going to discuss soon. The most important thing, all of you, our clinic doctors, to understand that the European guideline is based on the attributable risk, and the American guideline is based on the many studies, meta-analysis. However, both guidelines set up the therapeutic blood pressure goal less than 130 over 80. So the goal for the both guidelines are all over the world, your blood pressure should be less than 130 over 80. Okay. So why this study was done? The study was done to look at the effects of blood pressure, systolic and diastolic, on cardiovascular outcome. Cardiovascular outcome means what? Heart failure, ACS, these kind of things, etc. So both systolic and diastolic hypertension independently increases the risk of MI or stroke, regardless of the hypertensive definition or hypertension definition I discussed with you earlier. So remember, this is a very important slide, very important concept, and you should take this message to your home. What about the white coat hypertension? Everyone knows that if a person comes to the hospital, he became anxious. So if he has a normal blood pressure at home and office blood pressures are high as compared to the guidelines I mentioned to you, so how to screen this white coat hypertension? Is only one way. What is the way? You can do the 24-hour blood pressure monitoring. So white coat hypertension is common around, according to the studies, almost 20 to 30% of the patients, they have white coat hypertension. If you do the 24 hours ambulatory blood pressure monitoring, you can divide this thing, or you can differentiate this group between hypertension and normal blood pressure. If you have a normal blood pressure, it means that your prognosis is good. So 24-hour blood pressure monitoring, ambulatory monitoring is very important. It can assess the nocturnal hypertension. It can differentiate between the home and the office blood pressure. And on the top of that, some patient has mask hypertension. So you can look at the target organ damage. They have a target organ damage despite they have a normal office blood pressure readings. So this slide I explained to you. In this slide, the most important thing, if someone has a mask hypertension, means he has a low blood pressure in the office, but high blood pressure in the 24-hour blood pressure monitoring. This is very important, and they may have a target organ damage. And target organ damage, when we said, it means that patient has a structural and physiological alteration in the endothelium or in the vessels, like stiffness of the vessels. So this is, or patient have an objective evidence of target organ damage, like proteinuria, like LVH. So you remember these points. Sustained hypertension, both blood pressures are high at the office and 24 hours. Nocturnal hypertension, when the systolic is more than 120/70. And remember, for 24-hour blood pressure monitoring, because we are a cardiologist, so we should have a 20 valid readings in the daytime and 7 valid readings in the nighttime. Okay, so JNC8 guidelines, I think everyone knows about it, and these are the very important guidelines, and you should read it. This thing really, very important subject for all, for GPs, for medical specialists, for anesthesiologists, for every category of the medicine. These guidelines are very important. So JNC8 hypertension targets anyone who is above 60 in an older age group. The systolic blood pressure should be less than 150 and diastolic less than 90. However, if a person is less than 60 years of age and patient has a target organ damage, for example, CKD, due to anything, or target organ damage, or diabetes mellitus. Diabetes mellitus, very important factor, very, very important risk factor. Then the target would be systolic blood pressure less than 140 and diastolic less than 90. Okay. These are the main JNC8 guidelines based on this trial. And this trial basically in the age group of above 50, the systolic blood pressure in the range of 130/80 millimeter of mercury, and they have increased cardiovascular risk. And in that group, they exclude diabetes or stroke patients. And they divided that group in this trial into intensive blood pressure monitoring and a control, with a control of systolic blood pressure of 120 millimeter of mercury or less, and a standard blood pressure group, another arm, with a goal of 140 systolic. And they titrated the medication. What they found out that, and the main purpose of this, objective of this trial is the primary outcome is ACS, acute MI, for example, stroke, cardiovascular death, or decompensated heart failure. So in this trial, in intensive group, they use more medication. In a standard group, they have less medication. The blood pressure readings are definitely different. In intensive group, less than 180. In a standard blood pressure group, like blood pressure was like less than 140. The primary outcome, there's a significant difference in the primary outcome in the intensive group, 1.7 versus standard group 2.7. However, in intensive blood pressure group in this trial, they have higher rate of adverse effect like hypertension, dizziness, electrolyte imbalances, etc. So this trial is very important. And again, this trial suggested the blood pressure, you should not drop it less than 120, keep it in the range of less than 130 to 80, okay? Okay, so now according to the 2017 EHA guidelines, and there's nothing published later on, if you have a normal blood pressure, don't do anything, do not give or do not prescribe any medication, promote optimal lifestyle, promote healthy lifestyle. If you have an elevated blood pressure, which I discussed earlier, lifestyle modification. Remember, lifestyle modification, no meds, no polytherapy. Reassess them 3 to 6 months time. However, in the stage 1 hypertension, the important thing, clinical assessment, ASCVD. What is ASCVD? It's the atherosclerotic cardiovascular disease score. It is basically, this score was created by the Harvard Medical School and MGH. And this score is a very valid score. And if the score is more than 10% over 10 years, in such group, you need to treat the hypertension. If the score is less, then not treat it. If the score is less, ASCVD score is less, the ASCVD score, I can send you the link and you can put it, the app in your mobile. And while you are doing a clinic, you can assess for every patient. Even those who are listening to our lecture, they can assess their score as well. It includes like age, sex, ethnic background, white or black or Asian, systolic blood pressure, diastolic blood pressure, LDL, blood glucose. And this score will not give you only the risk for cardiovascular event, however, it gives you the bleeding risk as well. Anyway, so if the score is less than 10%, don't do anything, no medication, lifestyle promotion, and reassess the patient. However, if the score is high or the patient has a classical definition of systolic 140 over 90, diastolic, start the medication. Start the medication. This is very important message. This is a take-home message. Remember this slide, please. So we excluded already the white coat hypertension. What is the stage 2? So use of ASCVD risk score and guide the threshold for hypertension. If a person on my left-hand side, known CVD, like I mentioned in my second question, patient has an acute MI LED stent. So for secondary prevention, if the blood pressure is more than 130 over 80, you can start the medication. You can treat that patient. You can treat that patient. Blood pressure more than 130 over 80, you start the antihypertensive medication and lifestyle. Or ASCVD score more than 10% in 10-year risk, primary prevention in that group, you can start the medication. Aspirin, you should not use as a primary prevention until and unless ASCVD score is more than 10%. The score is high. In high risk group, you can use it according to the trials, SN trial, FM trial, and so on. And if the patient is compatible, if he has a low bleeding risk, then you can use aspirin. Aspirin nowadays is not for primary prevention, and you can assess the ASCVD score. These are the very, very important messages for the practical guidelines to treat your patients. However, if the score is less, now score is risk, in that patient, you should not start aspirin. Okay, but the blood pressure is high. The systolic blood pressure over 140, diastolic is 90. The medication is must, regardless of the score. If the pressure is 140 over 90 and lifestyle modification, medication is needed. So this is the whole summary of the guidelines, of the treatment. So please remember it. Okay. In the older age group, you have to make sure if you drop the pressure less, patient will have symptoms. So the most of the guidelines from family practitioner, from the American College of Physicians, they recommend anyone adult who is 60 years of age and the blood pressure is more than 140, you can reduce it, okay? But always discuss the side effects and always explain to the patient the effects of the medication, okay? The benefits of hypertension. This is a very important slide again. What are the benefits? Why we are treating hypertension? This is a very important slide. As I tell you, according to the WHO, almost like, billions or 1.5 billion of people are affected by hypertension. Okay? Hypertension is killing 10.4 million people in a year. Can you imagine? It's killing 10.4 million people in a year. We are in the era of COVID-19. Maybe you have a death of like 500,000. Hypertension is killing such a big number of patients. And it is a disease of every society, whether low or middle income countries or high income countries. Everyone is affected. So you have to treat it. You have to diagnose it. You have to educate the people about the side effects, about the micro and macrovascular complication of hypertension, and treatment is essential. In this way, you can reduce the burden, the global burden of this hypertension epidemic or a pandemic. So why the benefits of hypertension? What are the benefits? Stroke reduction, 35 to 40%. Heart failure, can you imagine? Heart failure with reduced ejection fraction, for example, or preserved ejection fraction, for example, more than 50% of the patient, if you control the hypertension, it reduces the incidence of heart failure. Myocardial infarction, almost 25%. Lifestyle modification, everyone knows about that. If you lose weight by 1 millimeter of mercury, you can, by 1 kilogram, you can reduce 1 millimeter of mercury. Dietary sodium restrictions are very important, and I'm going to discuss again, and also moderate alcohol use. Weight reduction, I mentioned to you, if you lose weight, you reduce both systolic and diastolic blood pressure. If you look at the so sodium intake, usually if you look at the different trials, and you notice that for a normal individual, you need only 180 milligram of salt intake in your body. However, the guidelines suggested 1.5 grams is enough, and in special cases, 1 gram is enough, okay? In America, if you look at the different studies, in America, the average American is taking almost more than 3 grams of salt. So salt, I think our Pakistani food is full of salt. We have to request people, we have to tell our families, low salt is very important. Low salt to the patient. This is a very important message, and it's extremely important in reduction of the systolic and diastolic blood pressure. And by the way, salt is a creation of a natural, is a myth. So low salt, better prognosis. Exercise, I would recommend moderate exercise like 30 minutes per week, or aerobic resistant exercise like 3-2 times in a week time. And there are a lot of, if I go back, there is a lot of studies published in Lancet. There's a recent study called Pure Study between the basically prospective ethnic and the rural urban society study, and clearly demonstrated that in data studies, reduce salt intake, it will reduce the cardiovascular morbidity and mortality, and reduces the incidence of a stroke. It's published in Lancet in 2018. I did not put it because it will take more time. So some patients, they have a salt insensitivity of the blood pressure, and occurs mainly with age above 45 years old. Patients have a metabolic syndrome in women and non-Hispanic blacks. And I mentioned to you the salt reduction is very important. It reduces both systolic and diastolic blood pressure. Okay, so I will go to this slide because we are short in time. So if a systolic blood pressure more than 20 and diastolic is more than 10, okay, this is a very important slide. You have to use 2 medication. Is according to the guidelines. I'm not telling you anything from myself. So if the systolic more than 20, diastolic more than 10, from the basic definition, you have to use 2 medications. Important slide to concentrate on that. In general population, including the diabetes mellitus. Diabetes mellitus is an important risk factor. Whenever you have a hypertension, you have to screen for the other risk factor like diabetes mellitus, like hypertension, like hypertriglyceridemia, obesity, alcohol intake, smoking. All other risk factors are very important to screen. Renal failure, CKDs. So in general population, you can start with thiazide diuretic or thiazide-like diuretic. And everyone knows about the adverse effect, the mechanism of action. For my GP colleagues, thiazide diuretic has a lot of electrolyte imbalances like hypokalemia, hyponatremia. It can cause dyslipidemia, hyperuricemia. So remember these side effects, okay? Calcium channel blocker, always try to use long-acting dihydropyridine group like amlodipine, like nifedipine. These are the important things. Try not to use non-dihydropyridine group, okay? ACE inhibitor, everyone knows about it. ACE inhibitors are the cornerstone of the treatment in many, many cases of hypertension or angiotensin receptor blockers, okay? So in a black patient, thiazide diuretic is the first choice, along with the calcium channel blocker as per the guidelines, even with the diabetes, unless the patient has chronic kidney disease. And you can use ACE inhibitors and the ARBs as well. However, if a patient who has a chronic kidney disease, and how can you define a chronic kidney disease? Patient has proteinuria. Patient is diagnostic positive for proteins. Patient has high albumin-creatinine ratio, or patient has more than 300 milligram per deciliter of albuminuria. So in that group, please remember, you will not use thiazide, you will not use beta blocker, you will not use calcium channel blocker. The first option would be ACE inhibitor or ARBs, not N. Okay, I think I'll spend more time on that. ACE inhibitor or ARBs, do not use both the things, both medications together. Remember this thing. According to a lot of trials, these medications may harm the patient. It's a very famous trial in Lancet in 2018 by VA group. If you use these medication, it may cause hyperkalemia, it may cause AKI, okay? However, basically the some meta-analysis that's going on, further studies are going on to look at the effects of these drugs. But remember, for any patient who has hypertension with CKD, the first choice was ACE inhibitor or ARBs, and everyone knows about that. The mechanism of the ACE inhibitor, RAS inhibition, is you have to understand, you have to go back to your medical school and remember the mechanism of action of ACE inhibitors or ARBs. Everyone knows that ACE inhibitor block the conversion of angiotensin 1 to angiotensin 2. And angiotensin 2 is a very potent vasoconstrictor. So if you block that pathway, you are reducing the vasoconstriction, you're reducing the peripheral vascular resistance, thus, therefore, you're reducing the blood pressure. Thiazide, ACE inhibitor can cause cough, can cause angioedema, okay, can cause hyperkalemia, both the things, okay? So remember these things, and I'm not going the names of these medication. Calcium channel blocker, as I mentioned to you, it has some side effect like fluid retention, constipation, and next slide. So pregnancy potential, okay, a person who has a hypertension, he would like to get pregnant. Use calcium channel blockers or a beta blocker. Do not use ACE inhibitor. Do not use ARBs or other subgroups. Okay, so these are the best choices for you guys. Like methyl dopa is also another option, but it's a weak antihypertensive. So I would go with a beta blocker or calcium channel blocker. Very important subject. Any patient who has a MI, recent MI, acute coronary syndrome, depressed LV function, history of VF due to the acute MI, or a heart failure, in that group, you have to use first choice is a beta blocker. So guidelines now, they're including first choice in this group only, beta blockers. Okay, remember, this is a very important slide again. Beta blockers, those who have a cardiovascular outcomes, those who have a cardiovascular benefit, you will get it from the beta blocker, reduces the incidence of heart failure, improves the outcome, improves the LV remodeling, et cetera, according to the baseline, according to different evidence based on the different publications. So beta blocker is the first choice, and beta 1 selective, you have to use it like bisoprolol, like metoprolol, like et cetera, like carvedilol and so on. And the second choice will be ACE inhibitor or ARBs. So this is very important thing, and you have to take home message. Beta blocker can cause, everyone knows that, fatigue. Remember, fatigue. It can cause, it will unmask the hypoglycemia in diabetes patient. It can cause claudication. It can aggravate, if you have asthma. So these things you have to remember in this thing, okay? Stable CAD, a person who is not in heart failure, and the CAD, coronary artery disease, is stable. In that group, you can use ACE inhibitor or ARBs, angiotensin receptor blocker, or calcium channel blocker. So I hope you are getting, I think, the full information in terms of side effects, mechanism of action, and indication. Indications are very important, okay? A special group, I'll go to the diabetes, and our senior professor, Dr. Suhail Anam, is here, so I'm not going to touch it. There's an accordion trial. Try to reduce the blood pressure, and is a long trial, is a trial for almost 8 years. And if you reduce the blood pressure less than 120, it will not, the impacts on the cardiovascular mortality will be neutral, will be equivocal. So try to reduce less than 130, okay? And by the ADA recommendation of hypertension and diabetes, the target blood pressure, 140/90 or less than 90, and it depends on the patient characteristics, on risk factors, and other objective evidence of the target organ damage. However, if the patient has cardiovascular outcome, cardiovascular risk factor like ischemic heart disease, CAD, heart failure, or kidney diseases, which I mentioned to you, then your target will be less than 130/80. So these are the two differentiating points to remember, and that is the take-home message on the slide. Sleep apnea is common in Saudi Arabia, is common in European and American countries. If you use the CPAP, you may reduce the blood pressure. The evidence is less. However, you may reduce in some of the studies almost 10 millimeter of mercury. Okay, so resistant hypertension. In resistant hypertension, JNC7 definition, if the blood pressure more than 140/90 and the patient is compliant with 3 drugs, including a diuretic, and the blood pressure is not controlled, or patient blood pressure require 4 medication, this is the definition of resistant hypertension. And according to different data, the prevalence of, according to the famous Casser study, is almost 2%, and associated with the increased risk of cardiovascular morbidity, stroke, and heart failure. So I'm in short of time, so I'm going to be fast. Resistant hypertension, make sure there are a lot of causes. Patient is taking a lot of sodium, patient is not compliant with the medication. The compliance is a key issue. Remember, our pharmacists, our multidisciplinary approach, our GPs, our cardiologists, our nephrologists, is a teamwork. It's a teamwork. You have to, the most important reason patients are not compliant, polypharmacy. Patient doesn't understand the importance and the implication of the hypertension on the body. So always remember, tell the patient strict adherence, regular checkups, office and home blood pressure monitoring are key. Medication side effect, excessive alcohol intake, secondary causes of hypertension, these are all causes of related to resistant hypertension. Some medication can cause hypertension. You should know about it. Non-steroidal anti-inflammatory drugs like oral or COX-2 inhibitors, oral contraceptives, alcohol, erythropoietin, cyclosporin, and so on. So remember, whenever you have hypertension, a proper history is very important. Pharmacological history, drug history is very important. And if the patient is on these medication, try to stop it. Refractory hypertension. Definition: inadequate control of blood pressure despite using 5 or more medication, including a thiazide diuretic and aldactone. Is very rare, as happen in 3% of resistant hypertension cases. Okay, so in that group again, we have to reduce the sodium intake, we have to promote the physical activity. Treatment of resistant hypertension, we have thiazide diuretic, we have ACE inhibitor or ARBs, or in combination with long-acting calcium channel blocker. Long-acting calcium channel blockers, and try to use twice daily to maximize the effect. Spironolactone, alpha blockers, alpha beta antagonists like labetalol, centrally acting agonists, and vasodilators. So I'll tell you how to go in a stepwise approach to treat resistant hypertension. First approach, optimize the diuretic. So whether thiazide diuretic like hydrochlorothiazide, or thiazide-like diuretic, which is chlorothiazide, or a loop diuretic if the estimated GFR is less than 30 ml per minute. So I told you that thiazide are a very important medication in treatment of hypertension, and it has side effects. You should know about it. Second approach, optimize ACE inhibitor or ARBs, along with the long-acting calcium channel blocker. And the study shows that they are superior. If you combine ACE inhibitors or ARBs with calcium channel blockers, they are superior to ACE inhibitor with thiazide alone. And almost in 60% of the patient, if you use this approach, you can control the blood pressure. Third approach, I like this medication, spironolactone, eplerenone. This is a beautiful medication. We are not using it, and it can help in resistant hypertension. Make sure these patients have a estimated GFR over 30 ml per minute, and they don't have, spironolactone can cause, eplerenone can cause hyperkalemia, and make sure they don't have CKDs. And if you combine with ACE inhibitor, ARBs, or non-steroidal inflammatory, the increase of risk of hyperkalemia is there. And spironolactone can cause breast tenderness and gynecomastia, but all are dose dependent. Spironolactone, according to the SCOT trial, everyone knows about it. It can reduce both systolic and diastolic blood pressure. Okay, secondary causes of uncontrolled hypertension. Okay, which is almost 10%. Okay, so if a person is drug resistant, or a person has a drug-induced hypertension, a person who has a hypertension at a younger age, like less than 30, abrupt onset, accelerated or malignant hypertension, patient have a diastolic hypertension in the age group above 65. Usually in elderly, you have a systolic hypertension. Your diastolic curve will get down. You have a white plus pressure difference. So if he has a high diastolic blood pressure in the older age group, or patient has unprovoked or excessive hypokalemia, in that group, in that subjects, you should screen for the secondary causes of hypertension. Secondary causes of hypertension, common causes, sleep apnea, very common, primary hyperaldosteronism, stenosis. I will try to concentrate for a minute on each subject. Other causes are there, and everyone knows about it: renal causes, drug-induced thyroid diseases, pheochromocytoma. Remember, pheochromocytoma is very rare. It can present with sweating, palpitation, so on. And whenever you treat pheochromocytoma, do not use beta blocker alone. Always combine with alpha blocker. Otherwise it will accelerate the hypertension. So, okay. So let's see how to screen if you are sitting in your office and you have a complicated case and you have a clinical sign and symptoms of these diseases which are in front of you. I'm not going to in detail of that because already you have medicine knowledge is excellent. So if a person has a hypo or hyperthyroidism, like hyperthyroidism, you have a weight loss, you have tachycardia. So look for the TSH and 3 T4. Pheochromocytoma, best thing is the plasma metanephrine. Primary hyperaldosteronism, normal or low potassium. This patient may have muscle weakness. Look for the aldosterone level, if more than 15 nanogram per deciliter, or the ratio of aldosterone renin more than 20. Cushingoid features if someone has it, so do the dexamethasone suppression test. Renal artery stenosis is a very important thing, and I hope Dr. Naveed is here. He can put light on that. You can do a Doppler ultrasound, and you can do a CATA or MRA. Sleep apnea, you know about the sleep studies. Okay, so I will try to go fast. I'll go and work on renal vascular diseases. Almost 80 to 90% of the renal artery stenosis present with the atherosclerotic renal artery stenosis. Remember this thing, atherosclerotic renal artery stenosis, okay? And in that group, patient present in the frank or flash pulmonary edema is a board question. Renal artery stenosis, patient has some element of renal impairment, small kidneys, or renal artery stenosis by Doppler ultrasound, and presented with the flank pulmonary edema, think of renal artery stenosis. So atherosclerotic renal artery stenosis is common. It's common in men above 50 years of age, and usually it affects the proximal 1/3 of the renal artery, and you can diagnose with the coronary angiogram. We diagnose it so many times. And you can stent it as well. Fibromuscular dysplasia is common in women less than 30 years of age. It usually involves the distal 1/3 of the renal artery. Okay. So systolic blood pressure, if it is more than 180 millimeter of mercury, and diastolic is more than 120. Remember, whenever you have a patient in the clinic, you cannot say he has hypertension. You have to check the blood pressure, multiple readings, and you have to bring the patient again and again, 2 to 3 times, 1 to 4 weeks apart, and then you can make a diagnosis of hypertension. If it indicates more than 130 or 80 systolic, or in the European guidelines, more than 140 over 90. However, single reading, whenever you have a single reading, more than 180 systolic, more diastolic, more than 110, that single reading define hypertension, okay? So this is very important thing. If this blood pressure readings and the patient has symptoms or signs of end organ dysfunction, which already discussed earlier. So if the patient has a target organ damage, along with this blood pressure reading, it is hypertensive emergency, hypertensive emergency. If no target organ damage, it's hypertensive urgency. And these are the clinical findings in hypertensive emergency, like chest pain, acute pulmonary edema, dyspnea, neurological deficit, cerebral encephalopathy, and so on. Hypertensive urgency, no target organ damage. Hypertensive emergency, you have a progressive target organ damage, okay? In hypertensive emergency, patient may have hypertensive encephalopathy. I told you, acute pulmonary edema, acute MI, dissecting aortic aneurysms. And remember, whenever you treat dissecting aortic aneurysm, our target is to reduce the blood pressure from 180 or 220, whatever systolic is it, try to reduce it to around 120 systolic. Why? This is the only indication. You have to reduce it. Why? Because the risk of aortic rupture is very high. So you have to reduce it. Treatment of hypertensive emergencies, acute aortic dissection, systolic blood pressure less than 120 in first hour. It has a very high mortality. It has a very high mortality. Every 1 hour, patient has a risk of 1 to 2% of dying. In 48 hours, 48% chance of patient will die. So systolic blood pressure, you have to reduce it, and you have a lot of medication, you know, and I will tell you in a minute. Preeclampsia or eclampsia or pheochromocytoma. You have to reduce the systolic blood pressure to less than 140 in first hour. In first hour, remember this thing. And any other diseases of the hypertensive emergency, reducing the blood pressure by 25% max in first hour. 25% max in first hour. Try to reduce it to 160, 110 over next few hours, like 2 to 6 hours, and try to normalize the blood pressure slowly and gradually in 24 to 48 hours. This slide is important. It will help you in MRCGP International, in MRCP, in cardiology board. Always remember in your MCQs and always in your practical life as well. If patient have an acute intracerebral hemorrhage, okay? Patient has acute intracerebral hemorrhage. And what is the management of the acute hypertension? If the patient's symptoms less than 6 hours, okay, and the blood pressure in the range of 150 to 220 millimeter of mercury, if you reduce the blood pressure, what you will do? You will aggravate the ischemia. Remember, you will reduce the intracellular pressure, rebound ischemia. So do not reduce it less than 140. If the systolic blood pressure is more than 220 in that group, then lower the blood pressure with IV medication. The message is this: do not reduce it less than 140. You will rebound ischemia. You may harm the patient. Acute ischemic stroke, 72 hours from the CVA symptoms. Now, how to treat hypertension in that age, in that particular subjects. That particular subject, is he qualifying for IV lytic therapy? If he is qualifying, try to reduce the blood pressure from 185 systolic to 110 diastolic before the lytics. It may cause hemorrhage, it may rupture, okay? So this is, everyone knows about it. And try to maintain the blood pressure in first 24 hours in that range, less than 185 systolic and 110 diastolic. However, if he is not a candidate of the lytic therapy, then try to reduce the blood pressure less than 220 to 110 and no blood pressure lowering for next 48 to 72 hours. Okay, if the blood pressure is 220 to 110, make it slowly, look at the patient properly, monitoring in the neurological ICU and all these things, but do not harm the patient by reducing the blood pressure, by reducing the intracellular blood pressure, reducing the ischemia, increasing the ischemia. If the blood pressure more than 210 or 110 in that group, then reduce the blood pressure 15% in 24 hours. These are the very important messages. I hope you guys are taking it properly. And thank you very much for your time. Okay, so these are the parenteral vasodilators for hypertensive emergencies. They are the calcium channel blockers, sodium nitroprusside. I told you sodium nitroprusside is a beautiful drug. Try to avoid an acute MI and with elevated intracranial pressure or renal impairment. However, in dissection, I told you beta blocker is a key, reduce the heart rate, it will reduce the rupture of the risk. So always combine with the beta blocker. Nitrates are very important. We are actively using it. We are using it day and night as a bread and butter for cardiologists, for inpatient with acute pulmonary edema, heart failure. It may cause reflex tachycardia. Labetalol is a beautiful drug. It has alpha and beta blocking activities, and it can be used. Esmolol, we can use it as well. And metoprolol IV, we don't have it in our hospital. So in summary, indication for hypertension based on the stages of hypertension, which I explained to you, and the ASCVD risk. Okay, so whenever you have to treat the hypertension, you should memorize the stages of hypertension and what is the ASCVD risk score of that particular subject. Lifestyle modification and the treatment strategy for hypertension, I told you. I explained to you resistant hypertension and three-step approach. And I explained to you the malignant hypertension, hypertensive malignant emergency treatment, and secondary cause of hypertension. So if a patient I think you know all these things, I will omit. I'll go to the questions because we want to finish this lecture is too long now. So based on the guidelines, a 56-year-old black man, what is the initial therapy with type 2 diabetes and hypertension? The blood pressure reading is 152/87 with normal renal function and proteinuria. As based on the guidelines, the treatment of choice is a thiazide diuretic. Number C. I'm not doing interaction with you guys because I want to finish the lecture quickly, so you have to go back to your office or your work tomorrow morning. Okay. So the next question is, a 62-year-old woman with a history of LAD stent 2 years ago, office blood pressure average is 138/87. And what is the best treatment option for this patient in that patient? So if a patient blood pressure is 130/80, you have to treat it. Patient has a high risk in terms of ASCVD score, and he has LAD stent as well. Okay, everyone is getting the point. This is all according to the guidelines. A person who has a dissection, I told you, and blood pressure was very high, 210/95. He was tachycardic. What is the best treatment? The key was tachycardia. So I will not opt sodium nitroprusside. I will go for intravenous labetalol. That is the message. If you will not control the rate, heart rate, you will increase the risk of rupture. So the correct answer is intravenous labetalol. One more question, let's see. 50 years old female with long-standing hypertension, systolic blood pressure readings in 160s, BMI is high, potassium is on a lower size, 3.2 millimole, and creatinine is 1.1, and normal GFR. Patient is on amlodipine, patient is on lisinopril, patient is on hydrochlorothiazide. What is the most appropriate next step? So we are thinking of secondary causes of hypertension. Okay, so what it reminds you, if you go back to the secondary causes of hypertension, probably we are talking about primary hyperaldosteronism. So what is the best answer? I told you, you have to measure the plasma aldosterone to renal ratio according to our lecture. Last question, and then I'll stop. A 63 years old African American man with type 2 diabetes mellitus, which is a risk factor. Blood pressure is high, 160 over 90s, high potassium, is a normal potassium, 4 millimeter, for creatinine is normal, and patient is on 3 medication, thiazide diuretic, maximum dose of lisinopril, maximum dose of amlodipine. What is the most appropriate next step in this management according to my lecture? So patient has type 2 diabetes, patient blood pressure is 160s, patient has normal potassium, patient has normal creatinine, and already is on 3 medication, long-acting calcium channel blocker, ACE inhibitor, lisinopril, thiazide diuretic. What is the appropriate next step according to our learning so far from last 40 minutes? I would go for eplerenone or spironolactone 25 milligram per day. Okay, so these are the guidelines, and I will stop here. Thank you very much, all of you.
Yes, Dr. Asad, you want to say something? Are you hearing me, Dr. Asad?
Yes. You go ahead. No.
Okay. So thank you very much, Dr. Asadullah Roomi, for your valuable, informative lecture about hypertension. Hypertension is a very important topic related to the general physician as well as specialist. We received certain questions, and I just pile up these questions in groups. One of our colleagues asked a question that it is related to the primary care of the hypertension, that if some patient has been managing hypertension on medication for 1 to 2 years, and during that period he reduced the weight and changed the lifestyle modification, what is your advice if his blood pressure is normal? Can he skip the medication?
No, we have to stick to the guidelines. If the blood pressure is normal on antihypertensive medication, he should continue the medication. Okay.
It means that once somebody started on antihypertensive medication, he or she should continue the antihypertensive medication with the advice of the physician, treating physician. Am I correct, Dr. Asad?
You're correct. You remember the hypertension, we are not looking at the readings. It has a lot of impact on the whole body, as I discussed with the complication. So lifestyle modification along with the medication, as per the guidelines, you should control it. Do not stop the medication. Do not encourage the patient and the physician to stop the antihypertensive medication.
So the message is that if somebody blood pressure is controlled, usually the public is thinking now blood pressure is controlled, normal readings, so I have to stop the medication. They should not stop the medication. They will continue their medication according to the guidelines. Okay. A second question is that one of our colleagues, they asked that should we start beta blocker as a start of a management of hypertension?
The answer is no. The answer is no. You have to go back. The beta blocker is a first line only indicated in the patients with acute coronary syndrome or heart failure, or who has an acute MI. Okay, so you should not start beta blocker as a first line management. Look at the whole subjects. The first line therapy is thiazide diuretic along with the ACE inhibitor or calcium channel blocker, depend on the subjects and depend on the patient characteristics and the risk factors. Only beta blocker you can use in patients which I mentioned to you. Next question.
So you mean that beta blockers are not drug of choice to start the treatment of antihypertension? They have to follow the JNC8 guidelines, right? Yes, another sir. Question is that one of our colleagues, he asked that one of his patients, she has white coat hypertension, and usually when she's coming for OR, she has a very high readings. What is the management? It is related to, I think, stress or anxiety. So what do you advise as a cardiologist to manage this condition?
White coat hypertension, if a person is coming, because your question is that the patient is coming to the OR.
OR, yes. So that's why I mentioned this one.
The patient is in stress, anxiety, and all these things. You can control the hypertension in OR by different mechanism. Okay, it is the job of the anesthesia consultant who's dealing with the patient. In the hospital setting, if the patient has a very high blood pressure, for example, at home is 120/80, and then in OR is 200 plus, they start usually Smilol or other Labetalol to control the blood pressure during the intraoperative settings or operative settings. Once the patient is intubated, the blood pressure went down. Okay. I think Dr. Tazim, can you unmute Dr. Inam, our chairman of the academic?
Dr. Bukhari can unmute.
Yeah, sure. You can do that, but yes, I can. Yes.
Sajjad as well, and Dr. Adil Sufi. If these four are unmuted, it will be highly appreciated.
Sure.
Okay.
Sir, Inam is here.
Dr. Tazim, next question, sir.
Yes, the next question is that although you mentioned different condition and drug of choice to start as a antihypertensive management, but one of our colleagues asked that what is the drug of choice for hypertension management, especially in diabetes mellitus? Number 2, asthma and COPD. Number 3, chronic kidney diseases. Number 4, thyroid dysfunction, maybe hyperthyroidism or hypothyroidism.
It's a whole subject. It needs 10 minutes to discuss this case.
Yeah.
So the first thing you
but
said.
In short, for diabetes, what you'll advise? For COPD, what you'll avoid? Which medication should be avoided?
Okay, I think it's a long question. In diabetes, you can start with thiazide diuretic as per guidelines and combine with ACE inhibitor or ARBs along with the calcium channel blockers. However, if patient has renal dysfunction, okay, in that particular group, the first choice will be ACE inhibitor or ARBs, because remember all of you, for a renovascular hypertension in diabetes or diabetic nephropathy, the ACE inhibitor or ARBs, these are the only medication which reduces the proteinuria. And how they reduces it? They reduces the efferent glomerular pressure, intraglomerular pressure, and they reduce it by that. So this is the answer for that question. For COPD, don't use beta blockers. Of course, you can use calcium channel blockers and diuretics or angiotensin converting or ACE inhibitors. For thyroid diseases and endocrine causes, I think take this question in the end for Dr. Sohail Inam. And what you said more, I think one more subject you said?
Thyroid dysfunctions.
Thyroid dysfunction, I will, in the end, will take the Dr. Inam. I can answer it, but he's my mentor, so I will ask him to answer it. And Dr. Adil Sufi, I can see him. So thank you very much, Dr. Adil. Next question, sir.
Thank you, sir.
Dr. Shad, can you continue the question you have?
I would like to tell you one thing to all of you before. One thing, Dr. Shad, for all the audience, Dr. Adil is here, so it reminds me one thing. There is an angiotensin receptor and neprilysin inhibitors as well, which is, we call it Entresto. Entresto. Anyone who has a LV dysfunction, reduced ejection fraction, Entresto is a beautiful drug and it improved the outcomes. So in that group, you should not use ACE inhibitor or ARBs. Entresto is available in Saudi Arabia and you can use it. And Dr. Adil, maybe he's an expert of this medication. He can put a light on that. And we are using it from last 3-4 years in Saudi Arabia. One more question someone asked me, Apliranon, mineralocorticoid antagonist. It is available in PSCC. It is available in Saudi Arabia. Yes. And it is, we are using it in our hospital. Yes, Dr. Shad.
Dr. Shad? I have one question from my colleagues. So the question is, simple. What is the possibility that hypertensive patient can discontinue medication? It is a long question. I just make it summarize. So according to him, I have personally investigated the use of salt in our cooking. Salt intake in home cooked South Asian food is very moderate. Problems in hotel and fast food, plus using of canned food. So, what is the possibility that hypertensive patient can discontinue medication? I can take this question. If he can withdraw the salt food or canned food, or is it possible he can withdraw the hypertensive medication? Just to withdrawal of the, canned food or a modification of the lifestyle. And this is the questions.
Again, I will stick on the guidelines. Okay, salt, as
Yes,
you
right.
mentioned, doctor, very nicely, the salt has a lot of impact and it increases the systolic and diastolic blood pressure. However, it
Right.
depends on the patient characteristics. A patient has, for example, cardiovascular disease. Patient has diabetes. Patient has hyperlipidemia, like important risk factors. Patient has CKD. Patient has metabolic syndromes. In that group, you cannot stop antihypertension. Okay, if patient has nothing and patient is a physician or patient is a very educated guy, he can try. This is I'm telling you, if he can monitor office blood pressure and home blood pressure monitoring very accurately, meticulously, and his blood pressure is not going above the guideline, if he reduces the weight, if you follow the regular exercises, he may try. But this is, I will not go for a public and say you can stop salt and then you can reduce the salt and maybe you will get rid of the antihypertensive medication. I will not tell in the public. I will tell you to the doctor who asked the question. All over the world, 10 to 90% of the patients have a problem of the compliance. They feel that the blood pressure is okay and they stop it. And hypertension is a killer, is a silent killer. It damages the organs, the vital organs. So I would recommend not to go on that myth. If you are a physician, a highly educated guy, you can monitor pressures, you can try. But this is my personal opinion.
This question, Dr. Asad, Roomi, we have students from grade 8 and 9 as well, and they have asked question, how could we control hypertension with the salt intake, increasing or decreasing? Would you like to give them simple message?
Simple message is that low salt in your diet, okay? Don't take the mayonnaise, don't take the burgers, don't take the special breads, they have a lot of salt, okay?
Excellent.
So if you reduce your salt, if you take a healthy diet, fruits, vegetables, exercise, polyunsaturated fats, okay? So these kind of things will help you in controlling the hypertension at your home and your general community at last as well.
Thank you.
Yeah. So, Dr. Roomi, I have one question.
Yes, sir, please.
Yeah. Well, not from me. I mean, from one of the colleague. What about the Concorde? She is asking, what about the Concorde and some knowledge of atrial fibrillation, an AFB. I mean, the question is that she wants to ask that the Concorde can be given some tachycardia or atrial fibrillation, which I just saw this question. So
Yeah.
is there any relation?
So definitely, Concorde is what? Is a beta-1 selective blocker, which is a bisoprolol. Okay, this is number one. Okay, I mean, a patient who has arrhythmias, atrial arrhythmias, okay? For example, any atrial tachyarrhythmias, which could be SVT, AVNRT, or atrial flutter, atrial fibrillation, okay? So in that group, you need to control the rate, okay? So beta blockers are one of the drug of choices in that group. And she's right, and patient can be used for that group, okay?
Right.
Dr. Bada, would you like Dr. Tazim?
If you allow me, Dr. Asad, because I have been worked in the emergency department, and you are also dealing the patient. In our ER, we are giving metoprolol to control the rate. And according to the time framework, the bisoprolol we are rarely using for this rate control in atrial fibrillation. Concorde is a very good drug, oral beta blocker to be added to control the heart rate in different like premature atrial contractions, PVCs, and it has a very nice effects. But in our ER, we were not using bisoprolol. We were using metoprolol as IV, 10 milligram to control the rate, and after that we give the rhythm control medication to the patient.
Okay.
Go further.
So we are going outside the hypertension lecture. If you are dealing with atrial arrhythmias, okay, Concorde, metoprolol, carbidiolol, nebivolol, acebutolol, this is all the medications which are beta-1 selective. Metoprolol succinate is used in America.
Yes.
Okay. Bisoprolol is used in Europe. Okay.
Agreed. Yes.
Bisoprolol has a dual excretion. It can be excreted from the liver as well. Okay, that is the advantage that Dr. Tazim is talking about. Bisoprolol is a long-acting, is a beautiful drug, and it can be used. Both medication can be used. Okay, even carbidiolol can be used. But if you are dealing with atrial tachycardia, especially AFib, then the treatment would be different. Okay, you need to,
yes, exactly, I agree.
unstable, you need to cardio word and so on. We are not going in that discussion. Okay, so it's completely different. If you are dealing SVT, the drug of choice is not a beta blocker. Dr. Tazim is using actively, and Dr. Badr and Pasha. So it's a different subject.
We are SVT, we are giving adenosine first. And I am absolutely agree with you that Concor can be used, all beta blocker can be used for any supraventricular tachycardia. You are absolutely right, Dr.
Remember the calcium channel blockers as well.
Yes.
Okay, so I think we are prolonging the discussion. If you have one or two more questions, then can we go to Dr. Inam and Dr. Naveed and Dr. Adil, and we can wrap it.
There is actually our senior executive body member, Dr. Badr, hand is raised for quite long. So let him give him a chance.
Can we take Dr. Badr? Can we see him, please?
Yeah, Dr. Badr, please.
Assalamu
alaikum. Dr. Roomi, wonderful presentation. Really appreciate your presentation. I have a very wonderful questions for everyone. As you know, the young generation, they are having diabetic and hypertension, and they have facing a lot of problems. My question is that the young generation, after taking antihypertensive, they have impotency. There's loss of libido. Do you suggest any medicine which is very reasonable for young people to take as an antihypertensive? This is my question.
I mean, the sexual dysfunction or impotency, as I told you, that's why the guidelines, basically, what I told you in my whole lecture, do not use beta blocker as a first line.
Good.
In general public, you're talking about, you should not use a beta blocker or in a younger age group. Okay, the choices you have: a calcium channel blocker, ACE inhibitor, thiazide dietary, ARBs, and etc. So only this problem we are encountering, the cardiologist is facing it, because beta blockers with acute coronary syndromes, beta 1 selective, we are using it. Okay, and that is a very important question raised by Dr. Badr. We are facing a lot of difficulties, not in a younger age group, man. It is up to the 70 and 80 years old guy, and he came with this. It's not a problem for only the younger age group. So this is an important question, and the benefits of beta blockers is available with impaired LV function. There is a lot of data. We can change, we can switch over in that age group. First of all, your answer to the question is that in a younger age group, do not use beta blocker unless he has cardiovascular diseases. Secondly, those who have sexual dysfunction or impotency, you can switch over from Concord to metoprolol or from nebivolol. People react, sexual dysfunction is less with metoprolol as compared to beta Concord. This is my practical experience. And sometimes you can send these patients to the urologist and they can use phosphodiesterase inhibitors. Okay. So I think next question to Dr. Tazim.
Thank you.
Just let me add to Dr. Badr. Dr. Badr, if blood pressure is in young, you have to think about these secondary causes. It's very rarely that young people have a blood pressure that is primary hypertension. Usually at the age of around 30, they have secondary cause, and you have to search secondary cause in the young people for the high blood pressure. And Viagra is a drug of choice for controlling this problem which you have been discussed. And switching from one beta blocker, as Dr. Asad mentioned, it is another choice to see.
Viagra is, Dr. Tazim, for our junior colleague, sildenafil, which is a phosphodiesterase inhibitor. It will cause vasodilation, okay?
Yeah,
it will increase the BP.
Yeah, that is for sildenafil is good for the pulmonary hypertension.
The sildenafil.
Yes.
Exactly.
One of the most important for our junior doctors, sildenafil should not combine with nitrates.
Nitrates.
Okay?
Nitrates, yeah, contraindicated, absolutely.
Any question, Dr. Shad? Otherwise, we can tell Dr.
Dr. Roomi, Farha Nadia, her hand is raised for quite long, so we can allow her if you.
Please go ahead.
Okay.
Yes.
Dr. Farha, you could unmute yourself.
Dr. Farah, you can ask the question now. What you want to ask from Dr. Roomi or from anybody?
Okay, if not there, then Muhammad Ramazan. I can unmute you, Muhammad Ramazan.
Hello.
Yeah, he's there.
Go ahead.
Yes.
Can you hear me?
Yeah.
Yes.
Dr. Asad, thank you so much for wonderful presentation. I am Dr. Ramzan, consultant psychiatrist.
Dr. Ramzan,
hello.
Can we see him?
Yeah, I allowed him to.
On your video. Why not? Why not? I will start.
Dr. Ramzan is a consultant psychiatrist. He's a colonel from Pakistani Army. He's on deputation in Saudi Arabia.
Mashallah.
And he's our embassy clinic group. So I would like to request all those who are listening to us, we have a lot of psychiatric patients, and he's happy to do the telephonic consultation to our embassy clinic patients. Okay? Yes, please go ahead, Dr. Ramzan.
Yes. As I told you, as I have just a comment, it is a wonderful presentation, and I just wanted to highlight all the antihypertensive, particularly beta blockers and calcium channel blockers, lead to the depression and the mood disorders and bipolar disorders, which are the psychiatric diagnoses. So we need to keep in mind while treating all the hypertensive patients who are on chronic medication for the psychiatric morbidity. And all the psychiatric patients who are on the antidepressants, particularly as you mentioned about the venlafaxine tricyclic antidepressants, include in their group monoamine oxidase inhibitors and the fluoxetine from SSRI groups. They can increase the probability of being hypertensive, or they in the patients who are already prone to develop the hypertension. So just I wanted to highlight this reciprocal relationship between the psychiatric medication and the antihypertensive medication causing the psychiatric morbidity.
Thank you, Dr. Ramzan, for the very nice comment. It's a very important subject. As I mentioned to you in my first slide, Hypertension Guidelines of 2020, read that chapter. It has some data on the psychiatric patient as well. One thing I would like to tell all the audience, like venlafaxine, Effexor, as Dr. Ramzan mentioned, it can cause a diastolic high blood pressure. So always tell the patient that maybe your blood pressure will rise. You have to do the home monitoring of your blood pressure. And always rule out, if you take a history, if the patient is on like fluoxetine and other medications, so the patient and the doctor should be on the same page along with the psychiatrist to control the hypertension in such groups. And the beta blockers, as he mentioned, it can cause mood disorders. So
regarding the venlafaxine, if you would like, I can add that it's a non-selective norepinephrine and serotonin reuptake inhibitor. So norepinephrine is a very potent vasoconstrictor. That is one of the reasons that it causes hypertension, and a very clinical significant interaction with monoamine oxidase inhibitors because of the tracer amine that's called tyramine. And that's called hypertensive crisis, one of the major adverse effects. That's, I think, for all junior doctors and students who are here, we do definitely take this question in USMLE and PLAB.
I think I want to ask you if Dr. Roomi, you allow me, can I ask one question from Dr. Ramzan, because I want to take the opportunity to just add some information. I'm allowed to ask Dr. Roomi?
Yes, sir, please.
Okay. Dr. Ramzan, most of the hypertensive patients, they have got multiple comorbidities. So they have depression. So what is the drug of choice, safe drug, antipsychotic drugs or to control this depression? What is your advice for them? Dr. Ramzan, are you hearing us?
I think, could you, Dr. Ramzan, unmute yourself?
Okay. Yes. Okay. Am I audible?
Yes.
You were hearing me about Dr. Ramzan, that what is your advice?
Yes. I heard your question. Can you hear me?
Yes.
Yeah, now we are hearing.
Okay. Dr. Sahab, as per books, the most safe group of the antidepressant, which is recommended for the antihypertensive patient, for the hypertensive patient, is again the SSRIs, excluding the fluoxetine, like or citalopram are the drug choice as per the books. Okay. But again, if you ask about the clinical experience, as I've been treating most of the patients in Pakistan, these SSRIs can also, in some patients, switch the blood pressure on upper side. So I recommend and I prefer the drug metrazepine, which is cardiosafe, which is hypertensive neutral, and it is sedative. So this is, you can call it a 3-in-1 drug. which does not, if we start that, we don't require any anxiolytic for the, or any hypnotic for the sleep, and don't have any negative effect on the cardiac morbidity. It is safe in the hypertensive patient. But for GPs or other specialties, it is advisable that either you start with escitalopram or the citalopram salt. Okay, escitalopram usually comes with the Cipralex. It's the most famous drug.
Yes, I have seen most of the cardiologists, they are adding in Pakistan citalopram, risperidone, or buspirone. So citalopram is more safer.
Risperidone is antipsychotic drugs, and regarding the antipsychotic group, the safe group is the old antipsychotics like Serenase or the largectil, not the newer antipsychotics. Newer antipsychotics, which include the risperidone and olanzapine, they increase the obesity and indirectly they have the effect on the blood pressure. So they usually should be avoided or highly monitored when we are starting in the hypertensive patients.
Thank you, sir, for your valuable information regarding this.
Honored, sir.
Thank you. Can Dr. Shah, you take over further? Any question?
Can we take one question from Dr. Inam, because we are getting late now. It's 10:15 already.
Yes, Dr. Inam is here.
I don't know he's here or he left.
Yeah, sir, Inam is here, yes.
Dr. Inam, can you put some light on hypertension in the group of thyroid diseases?
So, okay, so very briefly, there was some talk about diabetes, and we would recommend first-line therapy should be either a calcium channel blocker or ACE or ARB. And then diuretic usually is the second or third line choice. Going back to thyroid disorders, so if thyrotoxic is usually systolic hypertension, beta blocker is the recommended drug of choice because you want to control the heart rate and it will lower the systolic blood pressure down as well. For hypothyroidism, of course, controlling the hypothyroidism alone is very effective. Usually it's diastolic hypertension. If you need to use a medication, then please avoid diuretics. So the recommendation is either a calcium channel blocker or ACE or ARB.
Anything, Dr. Inam, you want to add in this lecture? Anything?
Thank you very much. It's a great talk. Thank you.
Thank you. Dr. Naveed, you want to put some
chronic kidney diseases and
renal failure, or hypertension and renal failure, or glomerulonephritis?
Thank you so much, Dr. Roomi. I think you had a great talk this evening, and you have given really full view on hypertension. And you have mentioned already about diabetes and CKD patients. Obviously, we love ACE inhibitors and ARBs. These are the drugs of choice because they protect in long run the GFR. So it's great. I have nothing to add. Thanks.
Adil Sufi, do you want to add anything, sir?
No, sir. Very excellent presentation. And just a couple of comments. One thing is that the ACE inhibitors or ARBs, it is expected that you will have some increase in the creatinine, and that is because of the protective effect. So if you start ACE inhibitors and ARBs, the creatinine might go up, so don't be afraid of it. It is expected that you can have up to 30% increase in the creatinine. So, if there is less than 30% increase in the creatinine, don't stop the ACE inhibitors or ARBs. Keep following the creatinine and the potassium. So that is one thing. Second thing, the beta blockers, as you mentioned, the studies has shown that beta blockers are associated with increased risk of stroke. So that's why beta blockers, as you rightly pointed out, that should not be the first line of agent. Third is my question is about the diastolic hypertension. What is your view about isolated diastolic hypertension in young individuals? How would you take that patient? For example, 42-year-old gentleman with a diastolic blood pressure of 92. Would you treat him or would you not treat him? With no risk factor, American Society of Cardiovascular risk score of 5, and his blood pressure, his systolic is 120, diastolic is 92. Would you treat him or not?
Let this question to be answered by Dr. Inam.
His weight is, his body mass index is 23. And
are you listening to this question? A tough question.
Sir Enam, you could unmute yourself, sir.
Yeah, look, I mean, obviously this is not my area, but I wouldn't treat this patient. I think the data is not strong enough to give therapy to these people, especially if they are low risk. But obviously, people have different opinions on this.
Yeah, I think, Dr. Nam, I think I agree with you. By data, you will not treat it, but I mean, you have to look for in a young individual who has a diastolic blood pressure of 92. I would go for an ambulatory 24-hour blood pressure monitoring. Okay, I will look for the average diastolic blood pressure. If the average is in the range of the guidelines, for example, less than 80, I will not opt the treatment. Definitely, I'll not opt the treatment. It's a complicated question, for Dr. Adil. I will look for the secondary causes. If the blood pressure, as you said, the ASVD score is 5% and he's young, I'll search for the secondary causes. If the blood pressure above 90, 94, 95 diastolic, patient is young. So I will investigate, like, look for urine for proteins, ultrasound for the kidneys, and other endocrine causes for hypertension. Thank you.
I think the endocrine causes you're not going to find with that diastolic alone. So I wouldn't really go in that direction, but definitely you would make sure there is no end organ damage for sure, right? Because that would be an indication for therapy anyway.
For the end organ damage, for the audience, mainly, urine proteins are very important. ECG is very important. Remember these things. Fundoscopy is very important. These are the basic things. And if you do the fundoscopy, look for if you know how to do that. And when we were doing MRCP, we are keeping the fundoscope and we are checking the fundus. And look for microaneurysm, look for retinal hemorrhages, papillary edema. So these things are important. And LVH is quite important in terms of ECG or echo.
Can I say one?
Dr. Sajjad, can you unmute Dr. Ashfaq Bukhari? Dr. Sajjad is here.
Oh, okay, sure.
Because Dr. Sajjad is a consultant neurologist from King Fahd Medical City.
Yes,
so
Dr.
Sajjad. For some, taking up feedback in patients of a stroke and how to control the hypertension.
Yes, Dr. Sajjad is here. You can unmute yourself, Dr. Sajjad.
Dr. Ashfaq, I think we can stop in 5 minutes because everyone has to work tomorrow.
Can I make one comment if Dr. Sajjad is not around?
You are the star of the group. Please go ahead.
No, actually, to be honest, I don't like this. Hypertension is it's like a rolling ball. Targets are changing every I was just the more the studies are coming, at least for me, I'm getting more confused especially with the targets. And the European guidelines, they have their opinion. American JNC8 has their opinion. Other studies has the other guidelines, they did not supported higher blood pressure targets in the elderly. In fact, the Sprint, as you mentioned, it suggested that even in the elderly population, you should target the low blood pressure. So the previous guidelines, I was looking at one meta-analysis, and in that meta-analysis, the maximum benefit of anti-hypertension. So two things are which I thought is which I think is important. One thing is the hypertension, and second is the management of hypertension. That how much benefit you will get by starting the management of hypertension. So hypertension, I think that we are sure that 130/80, if blood pressure is more than 130, equal to or more than 130/80, then this is hypertension. Now the question is that how much benefit we will get if we start treating it. So the evidence is if we start treatment by 140/90, then the evidence is less. That's why the American Cardiovascular Score has come in. Recently, I was looking at one article, and they suggested that even the systolic, and then we have been taught about the J-shaped curve about the systolic blood pressure. That if your blood pressure is high, you have the bad outcomes. Then if the blood pressure is low, you have the, so there is a very short sweet spot, the J-shaped curve. But I was reading one paper, and they suggested up to 90, they did not see the J-shaped curve up to systolic blood pressure of 90.
Systolic.
Systolic. Yes, so up to 90, they said that there is a benefit. So I was perplexed, that we have been saying that there's a J-shaped curve. So where is that J-shaped starting to harm the patient? I don't know. So like it's a evolving.
Can you summarize, Dr. Adil?
And then it doesn't make any sense. Like, you know, we are saying that Sprint has said that Sprint excluded the diabetic patients, and it's suggesting that you should target blood pressure of less than 120. And Accord, which is saying that in diabetics, which is a coronary artery disease risk equivalent, they should not be targeted less than 120. So, but I think, as you rightly said,
there are discrepancies. You know, the message for all of us is that we are living in Pakistan. Let's talk about Pakistan. We have a problem in Pakistan. Okay, we don't have a system like in America. We are coming in the low-income countries. Okay, we don't have a system to measure the blood pressure, home monitoring, pharmacist availability to strict at the adherence. Okay, so in Pakistan, I think so education is more important, and go with the guidelines as European guidelines are more suited for that. Anyone who's above 140 and 90. And the other thing is, I think most important thing is the single pill combination therapy. These are the things, because different guidelines have different things. American versus Canadian and pharmaceutical industry come in that discussion as well. So single dose combination therapy medications are available in Pakistan. If local pharmaceutical industry is making these medications in a cheaper, amount and easily available to these people, this is the best way to treat our patients.
Yes, I totally the message should be that we have to treat hypertension, and we should target at least less than 140/90 by the medication.
Definitely. That's why, Dr. Adil, I mentioned to all the guys who attended, read the 2020 June article of Hypertension Society. This is a beautiful article, and they keep the guideline of 140/90.
Yeah, Dr. Tanveer, our senior advisor, Dr. Roomi, has some comment, I think.
Yeah, thank you very much, Asad, Roomi, and all the team. I think it's a very useful talk. But your hypertension, whatever guideline you're giving, when the patient coming to see any anesthetist in the room, this all guideline changed. So their hypertension, they all become hypertensive, and then you should refer. So
how do you use hypertension in the operative room, in the OR?
OR, yes.
Because we had American Society of Anesthesia, they have their different guidelines. Before we have this hypertension and diabetes was one of the moderate to high risk patient perioperatively, but now it's hypertension, diabetes, both come into the moderate group, moderate risk actually. Because we can control, we have more aggressive invasive monitoring, plus we have more aggressive drugs which we can get the result in seconds. But definitely baseline, basic education, basic knowledge must be there. Okay, what is at the end of the day, what perfusion pressures you want to keep, which patient is set on right-sided curve. So I think hypertension is a very interesting topic, and it's going to stay another 100 years the same. We will fluctuate, we will go with the new drugs, we will come up with the combinations, and inshallah, we will continue talking. Thank you very much.
Thank you. And Dr. Sajjad is here, so we can come up to that, Dr. Ashfaq.
I think, Asad bhai, you put your 2-hour lecture in 1 hour, okay? You speed up everything, and we were having difficulty to follow it, okay? So reduce down your speed. But it was excellent. You covered everything. You covered everything, mashallah.
Mashallah.
Dr. Tanveer, one query, taking advantage of your presence. When you will postpone the case on what reading of blood pressure?
No more. It's only malignant hypertension. Somebody is coming with the reading above systolic, say, persistent 180 plus, and even with the sedation, I don't cancel the patient if they are hypertensive only, and no end organ damage. Cardiovascular is okay. No ischemic pattern there. No recent MI or perioperatively having things. I don't cancel, because we have a lot of good sedations. We can keep them down. And still, if they are still on that range of malignant hypertension, definitely it's not safe. Then I just have to explain to the surgeon, and surgeon will postpone the case.
Dr. Roomi, Dr. Roomi, I have a simple question. You know the drug-induced hypertension like bevacizumab, Avastin. The drug of choice is Amlor or amlodipine. So, and bevacizumab also causes the proteinuria, well known. So what's the drug of choice? Should be the same as the calcium channel blocker, or it will be the AC inhibitors? One question. Second question, do you have the COVID-induced hypertension? Do you have experience with myocarditis, or how you will treat for this patient and COVID-induced hypertension? It is a treat as the same as the non-COVID patient. This is the COVID, not before the patient is not hypertensive. So, I mean, this is my two questions.
I think I'll answer the second question, COVID-induced hypertension. There's no change of guidelines, okay?
Yeah, okay.
We'll continue with the same thing, but we are doing it. We will not confuse the people. The first question I would say is better to be answered by Dr. Naveed Aslam, because you put proteinuria in that. But I would go for definitely I will go for dihydropyridine groups, amlodipine or nifedipine. Both these medication, there is some evidence that even nifedipine can reduce the proteinuria, okay, in different trials. And but ACE inhibitors, because I mean there is no study Avastin-induced hypertension. What medication can be used? I don't know about that. But I think both choices can be possible, can be used. I think ACE inhibitor or ARBs or calcium channel blocker. But maybe Dr. Naveed can subject if he wants.
Dr. Naveed is not around. Sorry, I just checked.
I think the last question taken by Sajjad Ali. Dr. Sajjad is here, and then we will stop because we are getting late now.
Yeah, okay. Dr. Sajjad, are you here? You can unmute yourself. Dr. Sajjad? I think no, he's not here. He's not around.
Just conclude, Dr. Bukhari. Just you conclude yourself for their sessions, and then we will leave.
Okay, Jazakallah khair, and thank you so much. As you know that we have initiated the lecture series on medical topics. Our expert for this is called kind of first lecture by our consulting cardiologist, Dr. Asad Roomi. He's a regional advisor from Kingdom of Saudi Arabia to Royal College of Physicians, UK, Edinburgh, and he is our president of Pakistan Doctors Group. We are really thankful for a very thoughtful talk. I think very academically and clinically integrated lecture. And I'm also thankful to the moderators, our academic wing secretaries, Dr. Shad and Dr. Tazim, and the panelist discussion by Dr. Adil Sofi, Dr. Naveed Aslam, Dr. Sohail Inam. He's also the chairman of our academic wing. Because of his guidance, this is what we have initiated. We request all participants, all our doctors, to come forward, inshallah, and we'll continue this one. Thank you so much for all your questions, for the very enthusiastic participation, and thank you to those students of grade 9 biology who participated in today's session. So inshallah, shortly this lecture will be available online on YouTube. Thank you, Dr. Roomi, and Jazakallah khairan.
Thank you very much. Masalama. Thank you. Good night.
Wassalama fi amanillah.
Thank you very much to all.
Thank you very much.